And we are a little bit behind. We have one more presentation before lunch, which is already lined up there. And that is for Andy McCulloch. Um, he's right there. So we'll help Andy set up the slides. And let me just comment on this last presentation. It was the last DBP to be funded, and we are very excited about it. There are still several levels of approval that have to happen, but I think we've got a very, very good beginning. So with that, let me introduce Andy McCulloch, who also got a linked R01 from the NIBIB, and this is for collaborating with IDASH on the Cardiac Atlas. It's an ongoing project joint with the University of Oakland.
Thank you, Lucilla. I'll try to be quick so that I don't keep you from lunch. The investigators of the Cardiac Atlas project include Dr. Alistair Young from the University of Auckland, who began this on a previous R01, Dr. Jeffrey Omans from the Department of Medicine, who's sitting here, Jim Perry from Rady Children's Hospital, Alison Marsden from Mechanical and Aerospace Engineering, and Lucilla. As you know, cardiology is quantitative, and I guess none of my movies are going to work. Oh well. And so we use atlases. What you would have seen here is a deforming model following the contours of the heart as a way of extracting quantitative information about morphometry and function of the ventricles. Looks like this one does work. This is the Cardiac Atlas Project's tool. This is the newest version that was just published this year that is used to automatically track cardiac magnetic resonance images in these patients, but with guidance from an experienced reader. And the result of it, as you can see, is this biventricular model of the ventricular shape throughout the cardiac cycle, from which comparisons can be made and analyses can be done. This is actually the first patient from the new study that we've analyzed. The idea behind this tool and the database that stores these images and models is that an enormous amount of information is gained from tomographic medical images of the heart and other organs that gets lost. It's used once a diagnosis is made, and techniques that we can then use together with machine learning to identify classifiers either of therapeutic outcomes or the natural history of disease, which can then go back and inform diagnosis and clinical management. And as I'll tell you, the focus of the renewal is on congenital heart disease, but just by way of background, the database itself has over 3,000 patients' images and contours in it. Most of them come from two studies, the MESA and Determine studies. MESA is a study of early atherosclerosis that most of these patients are asymptomatic. They don't have heart disease. And the Determine study has patients who have myocardial infarction. All the patients, of course, provide informed consent, and all the contributors have IRB approval. All the data are de-identified in a HIPAA-compliant manner, and we have tools for uploading and de-identifying, uploading, and analyzing and visualizing these data. When someone wants access to the database, they have to make a request, and then the specific data that they want access to will determine the specific terms of the agreement with the contributing institution that has to be made. There are a total of about 15 groups contributing data at the moment, And another thing that CAP does is host challenges. In fact, Dr. Young is in Boston at the moment hosting a challenge at the MICI meeting. Originally, these challenges were tools for automatically segmenting or analyzing cardiac shape and function. But now, as you'll hear, we're moving beyond simply analyzing shape and motion into predicting mechanics, electrophysiology, and fluid. And so this latest challenge that he's hosting this week is actually on biomechanical predictions based on these patient-specific images. All of the tools that the database uses are open source, both for the uploading and analysis. And there's an XML schema that is used to link the contours and the images to other metadata and de-identified information, as well as to track provenance. So the database itself uses DMC4Chi and has an interface that allows users to visualize the uploaded files and the three-dimensional models. So here's an example of the kind of analysis I was talking about. So what you're seeing here is the modes of variation in patients and asymptomatic patients from the MESA study, where what the animation is going through is plus or minus two standard deviations of all those patients. And so what you can see is both at end diastole and end systole, the most dominant feature is just the size of the heart. Some hearts are big and some are small. These have already been adjusted for the height of the patient. Okay? But then you can see that the second mode has some slightly more interesting information, that some hearts are wide and fat and others are long and skinny. And so that's the second mode, and we can explore other modes of variation between patients using these techniques. The viewer itself enables visualizations like that to actually be obtained through the Cardiac Atlas Project web browser site. Here's a more recent study looking at variations between the patients in the 900 patients in the determined cohort and 1,900 patients in the MESA cohort, where the variation that you see in the visualization is between those patients who have myocardial infarction and the most advanced adverse ventricular remodeling and those who are normal. And so in this way, we're able to obtain statistical classifiers of not only being able to distinguish between patients with myocardial infarction and those who aren't, but to be able to get some measure of the degree of adverse ventricular remodeling associated with the myocardial infarction. The focus of the renewal of the Cardiac Atlas has been on congenital heart disease, and here we're taking advantage of the experience of IDASH, working with Dr. Burns at Rady Children's Hospital, and the collaborators in pediatric cardiology at Rady are giving us data and are interested in outcomes of congenital heart disease patients, and these are adults, because now more than 90% of babies born with these congenital heart diseases, which in fact the most common class of birth defect, will survive into adulthood, and with the result that we now have more adults with congenital heart disease than children. And you can see that the palliative procedures, surgical procedures that were developed that have enabled these patients to survive and live into adulthood first started going into practice in the early 70s. And so we're only now seeing patients reach middle age and beyond who are living with congenital heart disease. And so there's great concern about how can physicians judge how patients are doing over time and which ones might need intervention. So the procedure that a lot of these children have normally sometime after 2 years of age is called the Fontan procedure. And this was a surgical procedure that was first used in 1971. It involves shunting diverting blood from the right atrium into the pulmonary artery in these malformed hearts that, for example, have no working tricuspid valve. And that enables the oxygenation of the blood to be improved and is therefore palliative, but the patients end up with a single ventricle. This procedure is now also used in other conditions like hyperplastic left and right heart syndrome, but the result is that the patient has one effective functioning ventricle. Sometimes it's a single left ventricle and sometimes it's a single right ventricle. And there are differences in outcome between these single ventricle physiologies, but no well-known ways of being able to identify how these patients are going to do in the long run. Many of them are at risk of ventricular enlargement, mechanical dysfunction and heart failure, and sudden cardiac death. As I said, it's very difficult to assess the risk, and medical imaging is routine. And one thing that's interesting and new for the Cardiac Atlas project is that serial medical imaging is routine using magnetic resonance imaging, and there aren't really many cardiac conditions, if any, where this is the case. So we have the opportunity, but also the challenge for our project, to be able to analyze changes over time in the same patient. But at the moment, there really are no quantitative criteria for assessing the risk of these complications. So I won't go through all the specific aims because I know time is tight, but the main idea is that we would like to use these methods to identify early markers of either compensatory or maladaptive remodeling in these patients with single ventricle physiology based on our Atlas-derived models from their cardiac MR images obtained over time. And we'll plan to get initially 60 patients at Rady, including at least 30 in whom we have longitudinal follow-up, develop these Atlas-based geometries and perform statistical analyses, test hypotheses that these statistical properties may themselves be classifiers of outcome, but go further and actually use these models not only as models of shape, but as models of mechanical, fluid mechanical, and electrophysiological function, and to test some hypotheses about flow dynamics and wall stresses in these patients. So again, I won't go through all of the progress that we've made to date. The grant was awarded in January, but we now have identified 20 patients with high-quality records. We've de-identified and uploaded data for 9 of them, 5 with single right ventricle and 4 with single left ventricle for tricuspid atresia patients. And another thing we've started to do, for which we're going to require help from Lucilla and her group, is we actually modified our IRB so that we could get more data beyond what the Cardiac Atlas project was already storing, particularly electrocardiographic and hemodynamic recordings. Now, it turns out these are available as PDF files. So we need to be able to de-identify those and extract some searchable metadata from them. And so we're starting to define some of those terms using ontologies like SNOMED and RADLEX. So finally, I just wanted to show you some of the challenges that we're working on. So the patient I showed you before that I mentioned was being modeled. This is a cross-section here that shows a major problem that we have. So this is a single left ventricle patient because there's a hole in the septum there. Okay? What you can see, the problem is the model doesn't know that because the model was based on a normal cardiac topology and we normally have no hole in our septum. And so the model filled in the hole. Okay. So we need to make new topologies for these complex morphologies in congenital heart disease that can then be used as atlases. And in order to facilitate the comparison, we don't want to have more of these than we need. We'd like to have an optimal number to capture the anatomy and the variation in the anatomy, but without creating a lot of different atlases. And so we've been able to build on progress that we've made recently, building models of the patient-specific models of the atria to study atrial fibrillation. And the atria have a more complex topology than the ventricles, as you can see. I won't take you through the workflow. But the important thing about this is we recognize that a feature in geometry that defines these different topologies is the presence of these nodes like these blue ones here that are called extraordinary nodes, and they essentially divide a geometry up into different topology regions. And so what we're working on now is means for automating and consistently classifying these different morphological defects in this topological way. And finally, this is just an example of a study that's under review now, where computational modeling of hemodynamics is, in patients with single ventricle physiology has been used to try and petition and understand what the different congenital heart disease phenotypes are that may be contributing to exercise dysfunction may be. And sort of in a, excusing the typo here, in an outcome of the study, it turned out that of all of these, atrioventricular valve insufficiency was the single largest effect, and most of these effects combined linearly without large interactions. So I know it's lunchtime, so I better stop.
Thank you, Andy. Any questions for Andy? Or everyone is so hungry that you're going to wait for it. All right, so thank you very much.